Okay. So today we have to handle midlife in the middle of the day. It's very difficult. Heavy menstrual bleeding. Many years ago, this was a statement by a patient. When I'm on my period, my doctor told me to lie down and rest. Thankfully, we've gone past that. And because of that, I can talk today. And the talk I'm going to do is very simple. A little bit of definition, a little bit of diagnostic stories, just touch about the treatment and case scenarios, and I hope I will not overshoot the time this time. So the dam holding up the menstrual bleeding breaks down. You get menorrhagia, metrorrhagia. As of 2010, we are in a Latin out, English in. So throw all the Latin out, and the term pops up. AUB. So HMB is just AUB. Out of curiosity, one of those Latin words are still being retained. Hope all of you know that. No. No. Nobody, all quiet, sudden silence. Amenorrhea is still there. Okay? Right. So when we talk of heavy menstrual bleeding, it's just a menstrual period with excessive flow. So it's just a type of AUB, cyclical but excessive flow. A menstrual flow for more than 7 days or a blood loss of more than 80 ml. So we're keeping things simple and clear. Incidence around 50 in 1,000 women, yes. But once again, data goes in referral centers. You get larger numbers, other places. So all these things have become very organized. All of you are very familiar with the palm coin. You know the palm refers to the structural abnormalities and the coin refers to the functional abnormalities which result in bleeding. Once this has been introduced, it's sort of put a lot more of clarity in our thought processes. And this helps us to deal with these situations much better. There are small gray zones. You have AUBN, not classified yet. Is this just like our old DUB story? When we just did not know anything, then we'll call it DUB. So that is still a slight gray zone, but if you can't find any reason, you will call it AUBN. So when we talk of HMB, what is happening? One of the studies which I found very interesting was that heavy menstrual bleeding is associated with increased omega-6 AA in the uterine tissues. So you'll wonder, what the hell is that going to mean? That means that you're going to have a lot more prostaglandin secreted. A lot more prostaglandin means, obviously, more bleeding. So this was a simple cycle which we think is going to happen. And that could explain a lot of our functional abnormalities in uteri which were otherwise looking normal. The commonest structural problems, polyps, fibroids, adenomyosis. We have issues like PCOS, endometriosis, and pelvic infection. So first we go to the diagnostic story. All of you are familiar with the hysteroscopic drama. But do we need to diagnose to treat? The NICE guidelines very clearly tell us that if the patient's general condition is okay, if you do not suspect any problem, you are fully authorized to first try and treat it without further examination or investigation. I think it's very nice that there's a clear statement like that. That means if any person comes to you with bleeding, you're warranted to first try and treat if you think she's otherwise all right. But if you think that the bleeding is severe, persistent, or if pathology is suspected, then you definitely have to investigate and rule out first pregnancy-related problems. Don't think midlife rules out pregnancy problems. The usual history, physical examination, the vaginal ultrasound is still the basic legs on which we continue the treatment. But if needed, the thyroid, rectal examination, make sure that the cervix is not the cause of the bleeding, and then do the hysteroscopy. In hysteroscopy, please be patient. Look around the whole cavity, and if in doubt, biopsy it. What are we trying to do in this whole HMB or HMB-AUB treatment? We are first trying to find out if there is an underlying etiology, and if that etiology is there, whether we can treat it and control it. Second, we are trying to improve the quality of life. Third, we want to prevent an episode of acute uterine bleeding. We are also trying to prevent and treat anemia because that's also going to pull her down. Finally, we are going to establish regular cyclical periods. But the end of it, the bottom line is we want to avoid endometrial hyperplasia and also later on malignancy. So once you have these goals clearly in mind, then your management becomes very simple. So you have a lot of guidelines. So if moderate, general condition good, use just conservative methods, hematinics, styptics, it normally would settle in a few days. If not, or if very severe, treat actively, replace blood, use hormones either orally or, IV, but it's very tough to get those things here. But if etiology is known, treat specifically. Treat also with that, treat the associated problems. Anemia, fatigue, infections are common problems which go with that. But while you're treating, be aware of the age of the patient and her age to menopause. Now, how you would decide, it's strictly arbitrary, but still, if a 44-year-old lady comes to you, she's not going to be menstruating for more than 20 years. So you can take a call on that, decide the age to menopause, and then ask the patient for her choice. Today, our patients are very, very choosy. Some will very bluntly tell you, I don't want those hormones. Others will tell you, I don't want surgery. So you have to choose and decide. And also keep an eye on the contraceptive needs of the patient. Because even at that time, a contraceptive pill may help some people. Some women at midlife also have medical comorbidities, hypertension, diabetes, others are common. So you are really have your hands tied in using some drugs. You have to be careful with all that. Medications for HMB, if you see the NICE guidelines, they're very clear. Option 1 is the medicated IUCD. Option 2, they suggest tranexamic acid, NSAIDs, and OC pills. And option 3 is the oral or the injectable progesterone. Now, I'm sure many of us will not agree with all these pictures straight away. But why they've said it is a very simple study saying that progesterone pills independently, if taken short or long course, are not as effective at reducing menstrual blood loss as the LNG intrauterine device. This has come in the Cochrane database. So most of us would straight away put our patients on progesterone. I would be definitely part of that. So that is one reason why this doesn't work out. The next question is which progesterone to use? Medroxyprogesterone, norethindrone, Dynogest, or as they asked in the previous thing, would some depot preparation be better? So once you see pictures like this, things are quite clear and you know. Now, I haven't been a big fan of immediately using medicated IUCDs for the simple reason that in a bleeding patient, you go and put that medicated IUCD. Most often I've seen her coming back within a week saying, sir, it's popping out. So I would prefer to first try and stop the bleeding and then think of putting it. But I think it's left to you to think over because this is in the guidelines from NICE. The other options which are still available, if you want GnRH analogs and maybe thyroid treatment if you have a severe hypothyroid. What about the surgical options for HMB treatment? The good old dilatation and curettage as a therapeutic measure. I remember many years ago when we were talking about uterine artery ablation or resection or TCRE in Calicut, somebody stood up and said, So you're sitting and talking of all this. I just take that curette and keep on scraping, everything goes off. Patient doesn't bleed after that. So I was very impressed when he told me that, one senior gynecologist. Dilatation, curettage still has a role. It is primarily diagnostic, but if you can cure it, I think therapeutically it would work out. The hysteroscopic myomectomy is a wonderful procedure as long as that myoma is submucous. If it goes beyond submucous, if it goes beyond 3 to 4 centimeters, please be careful, it can be complicated. But while doing the hysteroscopic myomectomy in a patient of HMB who's not interested in further pregnancy, you could very well resect some more of that endometrium. Because what you're trying to do is to reduce her periods, and this may help you to do that. So this is where we have to use our common sense in patients. We have had patients who are about 40, 42, completed their family. I take out that submucous myoma, scrape out some endometrium, and she says, I don't know what you did, sir, but I'm absolutely comfortable as my periods are concerned. Endometrial ablation with the balloon has gone out of fashion. Uterine artery occlusion for this is still not very clear, may be useful in very specific fibroids, and if you can't do a resection procedure. If all options fail, you think of hysterectomy. So I just take you through 2 or 3 simple case scenarios. Most of you would be familiar and could do a better job than me. You think of a 35-year-old professional. She's got 1 child. That was a normal delivery. She has not decided on her next child. She has very profuse, very painful periods. She's not happy with this. Her ultrasound scan shows just a 10-week size uterus, 2 myomas, 1 subserous at the fundus, 3 into 4 centimeters, and the other intramural, 2.5 into 3 centimeters. That's right lateral. Endometrium is 10.2 millimeters, ovaries normal. So you see the picture is pretty clear. Pathology looks very clear to all of us. The question is, are the fibroids causing the bleeding? The fibroids outside, not near the endometrium, we are not thinking of that causing the bleeding. But are the fibroids making the uterine cavity larger, thereby making the endometrial area larger, thereby making the bleeding more? Very difficult, but the bleeding is more. Any role for curettage biopsy? If you want, this patient was straight away put on tranexamic acid. She didn't get relief. She took hormones on and off, not happy with the bloated feeling. Dynogest she was not happy with. So finally, she got a medicated IUCD put in, but then came after 2 months saying, I'm still having spotting. So we just told her, we are not going to get worried, please try and live with it. She lived with it for 2 months, bleeding stopped, and she became happy. So could this just be a case of AUB-O? This is the other confusing aspect of AUB classification. AUB-E, AUB-O, a polyp, endometrial hyperplasia, malignancy. All these 5 entities comprise the endometrium. How we are going to draw the fine line, again, is a tough problem. Case 2, 55-year-old, previous 3 cesareans, irregular bleeding on and off. Again, large fibroids. Her problem, endometrial biopsy, showed no atypia. What to do next? No treatment, medical treatment, hormones or surgery. All these options can be tried out, but all have their problems. This is where I say we have to act like God. We have to decide for the patient, with the patient's support, which part of the treatment you think she will personally benefit, explain to her and try and do it further. The patient underwent TLH. She had a stormy post-operative period. And this is the picture which I'd like to say, that if your target cannot be met, you try and adjust the target to suit you much better. Finally, the perimenopausal bleeding. 51-year-old, 10 months amenorrhea with severe bleeding comes with HMB. hysteroscopy done, you go into the cavity, deep into the cavity you see growth, you take a biopsy of it, it comes as an adenocarcinoma. In proven malignancy, case is best handled by the specialist. So like colors, dealing with women at this age can be very tricky, especially with the perimenopausal woman. Carefully find the cause, discuss the options, and treat it effectively. So in conclusion, I'd like to say that FIGO introduced a system which made it very organized. It has solved some of our problems. It has helped us to treat heavy menstrual bleeding in a very organized way. Do not just criticize the system, adapt it and follow it. Thanks TOGSICON for the nice invitation, and any questions I could answer later. Thank you very much.